Hi, my name is Jen Drake, and I lead sexual and reproductive health work at PATH. I'm helping out with background organizing for this session today. And I am actually just going to end the slideshow format so I can look at my screen for a moment. Welcome to this session on digital high impact practices. Very pleased to introduce our co-chair participant today, Professor Mbonye of Uganda, who is a professor at the College of Health Sciences at Makerere University, and also previously worked as a policymaker and program manager at the reproductive health at the Ministry of Health in Uganda. So welcome and thank you for joining us today, Professor Mbonye. Professor Mbonye will close our session. I'm also very pleased to introduce Alex Omari, who will moderate our session today. He is the Technical Family Planning and Reproductive Health Officer at AMREF Health Africa. He currently works as the East Africa Knowledge Management Officer for the Knowledge Success Project, and has previously served as a task force and technical working group member for the AYSRH program at the Ministry of Health in Kenya. So very much looking forward to having Alex moderate our discussion. Let me just share a few quick details about how this is going to work today. We have 3 colleagues, one from Uganda, one from Mozambique, and one from Madagascar, who will briefly share their experiences with us after Alex does a very quick presentation about the digital health high impact practices. And all of that is just meant to kickstart our discussion. This session is meant to be very interactive. So once Alex introduces the discussion and we hear from our country speakers, we will then facilitate a moderated discussion. We'll encourage you to insert questions or additions in the chat. If you would like to speak to the group, I would suggest raising your hand on Zoom and trying to use that function, and we will do our best as co-hosts to make it possible for you to speak live with the group. So please bear with us as we're doing our best with the different tools in this virtual format. Really pleased to have you all here today. And if you have any questions about the logistics, feel free to put those in the chat as well. So I think I'll pass it over to Alex now and go ahead and project the slides. Hopefully you all can see them. Alex, are you able to start?
Thanks, Jennifer. So good morning, good afternoon, good evening from wherever you're watching us from the world. Welcome all. So my name is Alex Omari. I'm the moderator for this session. Today we are hosting a virtual roundtable program implementation community session to discuss on how high impact practices in family planning are being implemented in various countries. The in-depth discussions will focus on what's working and why or why not. Later, the panel will have an opportunity to share examples of implementation on the ground, successes, challenges faced during the uncertain times such as COVID-19, and the recommendations. So the high impact practices for family planning are a set of evidence-based family planning practices which have been vetted by experts against a specific criteria, documented. So the HIPs, which are the high impact practices, are identified based on 2 aspects. The first aspect is a demonstrated magnitude of impact on contraceptive use. The second aspect is a potential application in a wide range of settings. Here you are looking at replicability, scalability, sustainability, and cost effectiveness. So we have 3 categories of HIPs. The first category is enabling environment that addresses the systemic barriers affecting individuals' ability to access FP information and services. The second one is a service delivery that looks at how to improve the availability, accessibility, acceptability, and quality of FP services. The third one is social behavior and behavior change. This one look at the influence of knowledge and beliefs and social norms and how they are associated with FP. So next slide. So thank you so much. So in the previous slide, we had a look at different categories of HIPs. In this slide, we're also going to look at a new concept called enhancements. So a HIP enhancement is a tool or approach that is not a standalone practice, but is oftenly used in conjunction with the HIPs to maximize the impact of implementation and increase the reach and access for specific audiences. So the HIP enhancements are evidence-based, and currently we do have 3 of them, and they include, the first one is actually incorporating adolescent friendly service delivery elements into existing contraceptive health services. The second one is use of vouchers to facilitate equitable access to and choice of voluntary contraceptive services. And lastly, the third HIP is using digital technologies to support systems and service delivery for family planning. And this will be our point of focus for this session on digital technologies. Next slide. So as you can see in that slide, we'll be focusing on the 3 digital health briefs. The first one being the digital health for systems. And here we'll be looking at logistics, improving provider capacity. The second one is digital health for providers, which include the digital job aids, telehealth, digital training. And the third one, as you can see on that slide, is on digital health for social behavior change, which includes improving knowledge attitudes and offers alternative ways of reaching adolescents. So next slide. So this is a very unique slide. So for instance, this HIP, which is a high impact practice brief, is an HIP enhancement. It does provide an outline by looking at how digital technologies can support service providers to deliver quality contraceptives. At this point, I want to bring on board my panelists who will share with us the country-specific examples on what's happening on the ground, the successes, the challenges faced, especially during this context of COVID-19, and the recommendations for scaling up. So in no particular order, I'm going to invite my panelists for the session. And so my first panel member is Alan Namagembe. So Alan works with PATH Uganda as a digital health provider. And then the second panel member is Nobato Banze. Nobato Banze works with the Pathfinder International in Mozambique, and he'll be talking to us on the HIP of how they have been working with adolescents in the SMS platform. And then the third one is Dr. Yvette Ribaria, who is working with JSI Madagascar, and she'll be focusing on FP distance learning by IVR. So just to keep the discussion going, I'll move on to my first panelist, and I'll be inviting Alan just to give us a brief on what they are doing in Uganda as in terms of providing digital health trainings. Alan, over to you.
Thank you so much, Alex. Good morning, good afternoon, good evening. Just to start this off, as while at PATH, we aim to improve access and options to a variety of contraceptive methods. The digital health innovation I'm sharing today relates to delivery of DMPSC and contraceptive self-injection. DMPSC is the first widely available self-injectable contraceptive, and WHO strongly recommends self-injection as a self-care approach. And as we heard, also WHO recommends digital innovations for health system strengthening. So to introduce this product, health workers and clients need to be trained. And some of us may know providing quality training for these groups is a big undertaking. And now, as Alex hinted, we are having a challenge of how to move training and supervision forward in a context of social and physical distancing. So one of the goals of the e-learning is to train health workers, including community health workers who are closest to the women, to counsel and train clients to offer competent care. And while stakeholders and donors often get so excited about the idea of digital training and supervision approaches, we should know it's not a magic button. We need to balance optimism with realities like low mobile phone penetration in some of our settings, poor connectivity, and valid reading and digital literacy levels. In Uganda, we evaluated the DMPSC online training for health workers with an objective to understand the feasibility, acceptability, and cost effectiveness of the e-learning as a training strategy. We were not resourced to evaluate according to outcome-focused indicators, which should be a next important step. The course is currently available on Kaya website and PATH and had Ministry of Health approval to use this in Uganda. E-learners need a smartphone, a computer or a tablet, and internet connection to take the course. And the e-learning was followed by an in-person practicum, which aligns with one of the tips for digital health enhancements for family planning service providers to design a digital training program to allow the possibility or need to practice skills acquired in different formats. We conducted knowledge assessment, observation using the checklist for injection administration, and then also administered structured surveys. Quickly, what are the lessons learned? We learned that vast majority of the providers, accounting to 88%, who completed the e-learning mastered the material, suggesting that e-learning can be an effective mechanism to improve family planning knowledge, aligning to the high impact practice of improving quality of family planning services, including self-injection. A slight majority of providers prefer e-learning to in-person instruction. Blended approaches were also popular, especially among the community health workers. This also aligns with one of the tips from the high impact practices enhancements to follow a modular approach to digital training programs that allow flexibility and align with provider time constraints and preferences. While most providers who were invited, we invited approximately 600 providers, they took advantage of the opportunity to take the course. Slightly half, 48% actually completed all the 10 modules. And in both public and private, the community health workers had higher than average course completion rates compared to other participants. Network connectivity, lack of access to a smartphone, and time constraints were the greatest obstacles to participate in the e-learning. We registered great improvement in comfort level with the practicum to emphasize that e-learning may not stand alone for teaching practical skills like injecting. Now we want to work with, we are working with partners in Uganda so that we can use the e-learning as an option to support full scale of self-injection aligned with the Ministry of Health Scale-Up Plan. Thank you, and over to you, Alan.
Thanks so much, Alan, for that brief discussion on what you're doing with, around DMPSC. So I'm going to move to the next panelist, and I'm going to invite Roberto Banze, who is going to give us a brief on how they're working with adolescents using the SMS platform to overcome the barriers to contraceptive use. Over to you, Roberto. You're on mute. Kindly unmute.
Sorry, I was muted. Well, good morning. First, thank you, Alex. Good morning, good afternoon, good evening, everybody. Well, I'm going to talk about MSNS. So, what is MSNS? In response to the growing use of mobile phones in Mozambique, Pathfinder opted to develop a comprehensive test message program that targeted youth 15 to 24 with and without children, with educational message. So the goal of the project is to engage youth in a SMS-based role model story and informational messages that will increase knowledge about contraceptive methods, dispel common myths around contraception, address common barriers, you face regarding the use of contraception? Well, we identified the need for young people to receive information about contraception.
Hello. You seem to have lost him. Roberto, can you hear me? You seem to have lost him. Maybe you can move on to Dr. Riberia to take us through on how they're using the FP distance learning by IVR as we wait for Roberto to join in. Dr. Yvette?
Yes, thank you. So the experience in Madagascar, as you know, Madagascar is located in the southwestern Indian Ocean off the eastern coast of southern Africa. And it has faced, as many countries around the world, the COVID-19 pandemic, which has negatively impacted on women's access to essential services, including family planning throughout the country. In addition, routine supervision and ongoing learning that ensure quality of services to community health volunteers. They are two in each village, and they are unpaid. Were also limited due to travel restriction and limitation of group gatherings. Therefore, the USAID Community Capacity for Health program, implemented by GSI in 7 regions, developed interactive voice response modules, IVR, on COVID-19 prevention and responses and essential services such as vaccination, safe motherhood, family planning for community health volunteers and health facilities in partnership with VIAMO and the Ministry of Health. CHVs received SMS messages the day prior to receiving the learning module the next day on FP services provision and availability, for example, in the context of COVID-19, including the use of pregnancy tests and protection measures against COVID-19. As a result, the participation rate increased to 3 times within a 2-month period. The completion rate of lessons is 85%, and roughly half of the participants complete quiz at the end of each module with a high rate of correct responses. It was 90%. Over to you.
Thanks so much, Dr. Yvette. I hope we have Roberto on. Roberto, can you hear me?
Yes, I can hear you.
Go ahead.
I lost connection for a while.
Sorry for that. Go ahead.
Okay. So we have identified the need for young people to receive information about contraception, but also the need to support young people to identify strategies to overcome the multiple barriers they face in seeking contraceptive services and using contraception to delay or space pregnancies. We began to design this initiative with the idea that we wanted to provide not only information to youth, but also to try to foster reflection and strategies to overcome barriers and maximize facilitators for use of contraception and other sexual and reproductive health services. With this in mind, we started with one of the cornerstones Pathfinder's behavior change approach, which is the use of narrative or stories in order to present information in a format that is able to contextualize and highlight multiple dimensions of behavior. Unlike informational messages, realistically detailed stories permit observational learning and adaptation of information to their own lives and situations. In addition to the use of narrative, we also recognize that the need for young people to receive straightforward information on methods to combat myths and misconceptions. And finally, learning from other SMS interventions, which suggested the importance of some degree of interactivity to engage young people in the system. At the same time, Pathfinder, adolescent, youth, and sexual reproductive health programs are built on the foundation that young people health needs are not one dimension, and that we should maximize opportunities to provide integrated sexual reproductive health information and services. So we came up with 3 components. So one of the components, the first one was the story using barriers and facilitators. And the second one was informational messages on contraceptive methods. And the third was interactive frequently asked questions menu on range of sexual and reproductive health topics. So this is what I have to share briefly about the MCNS.
Thank you so much, Nobato, for those brief insights. Just to keep the discussion going, I'm going to now to move on to Alan, just to give us a brief insight on how COVID has affected DMPSC implementation within the service delivery context in Uganda. So Alan, if probably you can just shed some light on the effect of COVID-19 and how it has affected at the community level in terms of DMPSC service delivery.
Thank you, Alex. First to say that when this had just broken up in the country, we had lockdown, total lockdown, restricted travel, meaning even some providers had to work around how they get to facilities to provide services, those who are sick and those who had needed services, needed permits to travel. So there was definitely a negative effect on service provision, later on, even the training and all this. So what the Ugandan stakeholders, including Ministry of Health and partners, did was to issue a circular to really communicate to providers to have these services continue, including for all family planning, including DMPSC and self-injection, not only that. And the other bit was also to work around how to support the providers before we would go do physical support supervision. But this time around, we had to innovate and use some digital solutions like virtual support supervisions. We even had to train, conduct TOTs, training of other partners virtually to be able to escalate, to cascade the training and keep on track on some of our implementing plans to really scale up self-injection and DMPSC in the country. I would say this has slowed down. It is not up to the desired targets, but at least we are continuing with our scale-up plan. Thank you.
Thank you so much, Alan, for the brief insight on how COVID has affected the service implementation within Uganda. So moving on to the next one, I'll probably want to invite Roberto again, just to shed some light on the intervention that they have implemented, the SMS platform that they have been implementing in Mozambique. What is it that has motivated the country program to implement this program, and how the adolescent and the young people responding to the program? Nobato, can you hear me?
Yes, I can hear. Thank you.
Thank you. Okay.
Well, as I said during my first intervention, we have identified the need to come up with this intervention, since in Mozambique the number of users of mobile phone is growing, and we know most of the times here youth, they always stay connected to mobile phones during the day. So we thought that it would be good to have an SMS intervention targeted youth, and it could even be an intervention through digital social media, I could say, social media, or these new applications that already exist, like WhatsApp and others. But we have opted to develop this comprehensive test message-based program because we wanted to target youth who are in not just in cities, but also in very remote areas, in rural areas, because we know that only in urban areas is where we will have people with smartphones. Most of them are in urban areas, but in rural areas, those are the ones who actually need more information. So we after gathering all the information that we thought would be necessary and important, we then started designing the implementation of SNS, and had youth at the first implementation. During the pilot, we had youth who were peer educators enrolling other youth to the system. But then when we decided to scale up, we made the system open so that anyone who is interested, at least living in the areas where the projects are being implemented, they are able to register to the platform. And once registered, they have access to all the information that we have now there. And recently, due to COVID, we had to add one module to the system so that youth and everyone who is interested could, through a simple SMS, just with a keyword, could get information, interact with the system, and even do a self-screening of COVID, because we have made some configuration in the system that allows people to do a self-screening, and based on your answers, then the system will tell whether you have symptoms that indicate some risk of having or containing COVID. So this is how all started, and this is how we are now implementing.
Thank you, Nobato, for those insights. To our participants who are online, kindly, if you have any question, feel free to send your question via the chat. And remember, we are using the hashtag ICFPPI for this community session. So the next point of clarification, or maybe just to give further insights on how the e-learning platforms are working. And this one will go to Dr. Yvette, is on the e-learning platforms. We want to know probably what the e-learning platforms via the app or web-based platforms. Can you share some relevant or maybe relative advantages or challenges that you faced as a program when you're using the program?
Thank you. So the first time we introduced this system, so we start with having already a list of basic phone, mobile numbers from CS community health volunteers, as we use this system for paying the community health volunteers when they have some training organized by the Ministry of Health. And then we thought that the system will be very easy to introduce, as the community health volunteers already use the system for being paid. But finally, when we start to implement the IVR, so we found that only a very few CHVs were able to accept to participate and gave their consent. So we tried with our partner to find how we can motivate and how we can inform the community health volunteers for them to accept to be part of the distance learning. So we use another system in the field, making more use the radio broadcasts for informing the community and volunteers about the platform. And then we found that more and more they adopt and they integrate the platform. And for example, at the beginning, we had about 1,000 persons accepting to respond to the lessons. And 1 month later, they just triple. So these are the kind of things that we take advantage that it can be a good system, but we need also to prepare the audience to accept and to be part of the platform. So that is the lessons we learned from this IVR. Over to you.
Thanks so much. Just maybe to keep the discussion going on the same aspect of using IVR, probably it will be good for us to, and the audience to know the kind of advice you'll offer to a partner who's probably looking towards replicating that kind of platform, or maybe trying to try it out. What advice can you provide to anyone who is taking that approach? Dr. Yvette?
Yeah, sorry. So from my perspective, using this kind of technology, and the first time you have to introduce it, I think that we need to know what is the best time for the audience to be ready to really participate in the platform and complete the lessons and making the quiz. So we need really to explain all of the process prior to really introducing and implement the platform. Then I think that in terms of follow-up of how they are really engaged and be motivated for continuing the learning, we need also to help them to understand that it's a continued learning. It's not all of the initial training as it is, but it's really a complementary training for these people. And for the health facilities, also to be aware that they have also to assist and support the community health volunteers to explain beyond the IVR for them to continue to improve the quality of their services. But I think also that we can expand this IVR as a link with the client, because if the client has some mobile phone, so the CHVs can take the advantage for asking them when they make the sensitization, so they can ask the phone number, for example, and be connected with the clients for interacting for the family planning related issues, or for reminding the follow-up appointment, so they can be connected, and then they can also make a distance referral to the CSB. So I think that the platform is good as it is, but we need really to inform the communities how they can expand the use and for them to continue to take advantage of using the system in a long term. Thank you.
Wow, thank you for those insights. Just now, I'm going to move to our audience who are online. I'm going to pose a question to each one of you, and maybe you can relate to the kind of work you are implementing wherever you are. So I'm interested, and together with my colleagues, if you have not implemented any digital high impact practice, why is that the case? And can you kindly share on the chat what is the biggest challenge you're experiencing with the digital hits in your context? So we'll be happy to read some of your insights depending on the context in which you are implementing your programs. Thank you so much, Dr. Yvette, for those wonderful insights. So the other point is basically looking at how the program is being implemented, the platform where it has been kind of like hosted, and the dynamics of implementing the program. So the next question I'm going to pose to my panelists, and this will go to Ellen. Our audience is interested in knowing how long it took you to train the providers via e-learning, and how long the sessions were, and what kind of or type of facilitation was needed for you to be able to kind of like administer this training. Alan, over to you.
Thank you. So regarding the sessions, there are 10 sessions for the full e-learning course that we administered. And each session should take about 10 to 20 minutes, except for the self-injection counseling, which takes some good time. And but providers took an average of, I think, 2 weeks to complete the course. But just to say, it was not continuous for many. Many of them would take it at their convenient time. I know there's a few who could take it in a couple of hours, but on average, it was 2 weeks. For the motivation, we gave a data plan to providers who had enrolled and started on the course to a particular extent to show commitment. And we also had support in the districts for those who needed to navigate the course, who had challenges. We also did training peer support, like those who were interested and able to support their peers were trained to give that support. Thank you.
Thank you so much. Just to add on to that, Alan, do you have some insights on why providers preferred the e-learning versus the traditional trainings?
Yeah, some of the preferences to the e-learning vis-a-vis the in-person, one to say is it was more attractive to the private sector providers who are rarely targeted for the usual trainings. Many times we run into trainings and are offered to public sector providers. Actually, at one point we had to stop them because we needed to hear insights from the public sector providers as well. So we had to stop them from enrolling. But the other motivation was the flexibility to take it at any time of their convenience. And then they didn't have to probably leave behind some work and come back to it later. But these and often they took it in the evening or after their duties. Thank you.
Thank you so much, Ellen, for that. Dr. Yvette, I'll move on to you. And we have a question from the participants. And the question is in regards to how you integrated a blended learning approach when using IVRs and SMS. Maybe you can share some insights.
Yeah, so prior to the day receiving the IVR, so the participant got a SMS message in their phone. Then the day of the IVR is coming, so there is, they can choose 3 languages. So there are local languages, so they can choose, and they press the button for them to hear the voice of the lesson. So when at the end of the lesson, it's a 5 minutes lesson. And after the lessons, they are redirect for making a quiz because there is a question related to the lesson that is asked, and they have to press 1 for the right answer, 2 for the false answer, and 3 for them if they do not understand the response, and for them to go back to the question. So that is the combination of using the SMS and the AVR. And when they miss the lesson, they have 24 hours to go back to a number of the phone and just call this number for them to again have the IVR come in, and they can follow the lesson at this time. So that I don't know if I respond to your question. Thank you.
Thank you, Dr. Yvette, for those insights. And we had a participant ask a question regarding internet connectivity. So one of the participants in this session noted that there is a big challenge for digital HIPs, especially where there is low smartphone penetration and poor internet connectivity, especially in the rural and the poorer peri-urban settings. So probably Nobato can give us insights and even talk us through about those kind of challenges that they are experiencing in the SMS platform, and how you try to address this in your context within your program. Nobato?
Hello, yes, Alex. So
go ahead.
Yes, just want to make sure that I got it right. The question is related with connectivity, right?
Yes.
Yes, well, regarding connectivity, since we are implementing an SMS program, we actually are unable to track receipt of messages. So it's a bit, let's say, I don't have the statistic, I don't have the numbers exactly to say what number of clients received the specific SMS. So even that is one of the challenges that we, the challenge and lessons learned during the implementation of this program, because we are unable to track the receipt of message. But we are still working with the aggregator and also the local mobile carriers to see how we can have this information, because of course some of the numbers probably are already offline, not in use, and we keep sending message to those. Yeah, that is what I would say regarding specifically to the SMS integration. But here in Mozambique in general, we are now in a better situation compared to when we started with the implementation of antennas, because during the pilots, we have many network outages, and we had to restart the system many times because people could start with the registration, and after 4 or 5 messages, the system would take long to reply, and this was linked actually with the capacity of the mobile carriers. But over the past years, they have invested a lot on their infrastructure, so now we don't have this problem. At that time, we're even doing we're having 1P educator registering the youth, but now with self-registration, we don't get any problems, even in rural areas.
Thank you so much. Dr. Yvette and Alan, maybe you can come in and maybe share your insights regarding, we know that some of the considerations that are being taken into place when implementing the HIPs, we are looking at the aspect of sustainability, scalability, replicability, and even cost effectiveness. So in your various programs, can you comment on how probably the cost effectiveness and potential for scale up at your interventions? Maybe you can start with Alan.
Okay, thank you so much. And as we had, our biggest challenge to completing the course were access to a smartphone and connectivity challenges. So we are working to get a solution that can be whereby providers can take the course offline and using phones that are not necessarily smartphones. And probably this can help us to, as we scale up, also to tackle the challenges for those who are not able to get a smartphone and those who are not able to have connection to take the course. Thank you.
Dr. Yvette, regarding your IVR intervention, maybe the considerations for scalability, sustainability.
So in addition for that, I think that in terms of sustainability, we need definitely to work with communication operators, because even we talk about the platform and using some basic mobile phone that are already available at the audience. So we need to pay for sending these messages and using the SMS. And I think if we would like to make a scale up, we need really to partner with some private sector to pay for that, because we cannot sustain for one partner to pay for sending this message for a long term.
Thank you so much. To our participants online, I believe you are getting your insights. We had asked you on why you are not implementing the HIPs and what kind of challenges are you foreseeing in your various programs. Maybe you can just share your insights in the chat and we'll be able to share with the other participants. Just to let you know that you can use the hashtag ICFPPI. That is the hashtag we're using for the community sessions, just to share your insights with the other colleagues who might be wanting to learn more about the digital technology. So moving forward, now we're looking at still the aspect of sustainability and the cost effectiveness. So Nobato, we know that you're having the SMS platform, which is a low cost intervention as compared probably to the internet platform. So how, probably what are some of your comments regarding how to scale up the program that you have, and even how you can advise others to replicate that kind of platform or maybe program in different countries globally?
Okay. Well, implementing this program has been something really exciting. Especially when we look at the messages that come that get to the inbox, and we are able to see many unrecognized messages. I call it unrecognized message because the system has been programmed to respond to specific message based on a keyword or when you are in an interaction on a specific model. So, because what happens, you have many people sending messages wanting to get more information. Others, they are pregnant and they say, I would like to get some help. How can I get some help? Because I'm pregnant, I'm feeling this and that. And those messages actually, they never get a reply because no one is there behind to read all the messages and reply to each message based on the preoccupation that has been posted. So, and others, they're just there to share their personal experiences and also to to advise on the story, since they receive specific stories like a soap opera, where they in a daily basis or every 1 day they receive one chapter depending on the project. They sometimes get excited and keep advising the person, supposedly the person who is sending, not knowing that actually it's a system that has been pre-configured. So one of the big things that we have to consider when we want to scale up is to negotiate a cheaper price of SMS, because when we look at the SMS, we think this is something cheap, doesn't cost so much an SMS. But when you have a high volume of messages being sent in 2 ways, yeah, you end up having a big bill by the end of each month that you have to pay. So we have to get very prepared and find ways to have cheaper prices, or even negotiating with MOH and other departments of the government to see if those messages specific to health can be sent with no without any charges, because this is something that sometimes is possible, although it takes a lot of time to get all the authorizations. So when we think that the intervention can have better results, we also have to consider partnering with other organizations that reply to messages, like specific message. Especially here in Mozambique, we have other organizations who have SMS interventions, and the difference is that those or that specific organization, they reply to every single message that is sent to that platform, because they have technical staff sitting, reading all messages and replying to all messages related with sexual and reproductive health. So this is something that maybe this integration will be very, very useful, and will allow people that are registered on the system to have responses to all other personal concerns. And at last is sustainability, because this kind of interventions, it should not be just a standalone program. It should be linked with one specific intervention related with community, where we have some interventions in the community, we have some interventions at the health facility level, because this will complement what we are doing, what we are transmitting during the interaction with the internet. So those are my thoughts and contributions for now.
Well, thank you so much, Nobato, for that. Just as we come to the close of the session, before we close, there's some question that is addressed to Ellen on capacity building of service providers. And our participants have noted that capacity building does not necessarily translate to service delivery as a result of incompetency, which is normally strengthened through mentorship. They want you to share on how FP e-learning competency was achieved for your program. Maybe you can share some of your insights on how you achieved competency.
Thank you so much. So for competence, we produced short videos really to do training videos for and e-learners. For the e-learning, we followed that by a practicum, or to give an opportunity for those who needed to practice the injection technique and also get feedback and probably raise questions done. But that said, And I hear you that sometimes training alone does not necessarily translate into service provision. And oftentimes, even in our setting, before you do the post-training support supervision, implementation might never start. So that is important. And like you said, mentorships are key and critical. And that's why we said once in a while, we even had to do the virtual support supervision to know, yes, you trained, but what are you doing and how do we support you to get you practicing what you learned? And like we said, for quality assurance, we need to continuously support the providers to give quality service. So training alone is not the end, although it's always some limitation in funding that the support is limited. Thank you.
Thank you so much, Ellen, for that. For our participants, we would like to hear from you. What are some of your takeaway messages from the session, and what kind of insights have inspired you from the different interventions that you've had from our colleague in Uganda, Mozambique, and Dr. Yvette. So to our panelists again, just to wrap up, I want us to have like a 2-minute kind of wrap up, 2 minutes from each panelist, just to talk through the participants on probably how do we continue improving our digital technology work, especially documentations in the humanitarian development space. So probably I'll start with Nobato, just to have your closing remarks.
Yes, thank you. Well, that's something that we really have to invest more, because most of the time we do a lot during our interventions, but we forget to write, document it, and create opportunities where we can share our experiences like this one. So it's something that all implementers, all organizations should invest a little bit more, because with documentations we'll be able to anytime improve how we are going to, how we're implementing in the future. And people can also, from this documentation, others, if they're interested to replicate that intervention, they can have information has a base to bear and to improve and have a successful implementation of the project. Thank you.
Thank you, Nobato, for those wonderful remarks. Dr. Yvette, over to you.
I would say that we need definitely to engage the Ministry of Health or other ministries in charge of this kind of activities, so they can really think from the beginning how they can sustain, what are the approach they can use for continuing some of these introductory implementation, because for the projects, most of the time we succeed when we make the pilot or the introduction. But when we go to the scale up, sometimes we just abandon because we do not have enough resources to continue, or we cannot transfer correctly to the government for them to continue. Because in each country, they are really the foundation of the development for, especially for health. And in the area of family planning, this is the kind of thing that we can really transfer correctly and definitely to the Ministry of Health. Over to you.
Well, thanks so much, Dr. Yvette. Ellen, on that aspect of having your closing remarks and talking about scalability and just looking through the documentation aspect, What are your thoughts on that?
Okay, my thoughts are really to pursue a user-centered approach where we learn from the users and use that, document that, but also use it to improve the digital solutions that we are implementing. And then maybe just also closely say that we saw lower family planning knowledge among providers generally, and it raises the possibility of using digital or virtual options for continuous medical education to ensure health workers and providers are able to provide a range of methods continuously over time. So this can be as add-ons to where we are limited to do in-person capacity building or quality improvement sessions. Thank you.
Well, thank you so much, my able panel members, Alan, Novato, and Dr. Yvette. So to our participants, we are still having your takeaways from the session. We want to learn from you on your key takeaway from the session, and what are some of the examples that were given by the panelists that have inspired you and which you think that you might be able to apply that in your programs. So at this point, I want to thank my panelists for having a wonderful session with me. And moving forward, I'm going to invite my colleague, who is Professor Anthony Mbonye, who is going to give the final remarks for the session, and then we'll wrap it up. Over to you, Professor.
Thanks, moderator, Mr. Alex Omari, for this steering this exciting and engaging session. And I want to thank everybody who shared their examples and participated in this roundtable. Digital health high impact practices. I want to thank Aaron Namagembe from Uganda, Norbert Banze, and Yvette from Madagascar, sharing your experiences. This session was organized by the Implementation Subcommittee. This is a new subcommittee for ISFP, and it aims to develop opportunities and space in the conference for practitioners, implementers, service providers, governments, youth-led organizations, and activists, and the private sector from across regions and different sectors. And it is aimed to exchange experiences on what works and what doesn't, and adopt the do's and don'ts in the different contexts. This roundtable was one of those opportunities focusing on how impact practices have been implemented in the different countries, Uganda, Mozambique, and Madagascar. We know that many of you joining this virtual discussion might not typically get the chance to travel to an international conference. We especially wanted to hear from you about what is working and the challenges you are facing and how you are overcoming these challenges. We have shared the examples of e-learning, focusing on community health workers from Uganda, focusing on the youth and young people from Mozambique, and the distance learning and the different lessons learned and challenges in Madagascar. We are keen to help take this conversation forward to lead up to and at the in-person International Conference on Family Planning in Thailand. If you'd like to stay connected with us and with each other following our conversation today, we urge you to visit the implementation community page on isfp2021.org. In the next week, we'll find there a place to give feedback on how you found today's roundtable and sign up sheet where you can opt in to be kept updated on program implementation. We will also be uploading the illustration that our recording artist has developed to capture today's discussion. In addition, if you are interested in learning more about high impact practices in family planning, you can visit the website HIP www.highImpactPractices.org. You can strengthen the HIP briefs to support evidence-based programming by engaging in a number of ways, which you will find under the Engage tab on the HIP website. You can contribute your expertise in technical expert group, provide feedback on the HIP briefs, submit new brief concepts, and sign up for the quarterly HIP newsletter. If your organization is not already an HIP partner, you can find out more about joining the HIP partnership by reaching out via the contact from the website. Once again, I would want to thank you, Alex, Alan, Norbert, and Yvette, and the audience for participating in this exciting. I hope we have takeaway messages on lessons learned. And as we move out of this session, we are ready to improve scale up of family planning to those who need it using digital health solutions. Thank you again, and looking forward to keeping the discussion going on our road to universal health coverage with family planning. I thank you all, and this session is closed. You can leave at leisure.
Power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.